So welcome once again, and over to you, Bert, for sharing your thoughts. We hope to have a great time of listening to your experience and what you have learned over years of counseling and taking care of people who have been displaced and are refugees. Over to you, Bert.
Thank you, Santosh, for your kind introduction. Let me start with the presentation. We will overcome boundaries. That's what we will do this afternoon. We address mental health needs in refugees. And it's indeed a very actual topic nowadays. We will discuss the refugee crisis, which is ongoing. We will have some ideas on first aid in mental health. I will share some of the main psychopathology and the effect of migration on mental health. And then also I will conclude with some efficient approaches. Last year, they announced and said, can it be worse? Can things that we see in the world, there are many conflicts in the world, will they finally come to an end, yes or no? And there's a website, as you see on the slide. Slides will be shared with you, and you will also find these references on the slide later on. That the conflict we see now in the Ukraine was more or less prophesied, unfortunately, that these things would happen, could happen, and indeed we are seeing them now. The conflicts in the world are increasing, whereas we would like to see them decreasing. Next. I'm not the only one who would like to see them decrease. It was John Lennon who in the 70s said, we are more popular than Jesus Christ. And his famous song, which I guess you may have heard also on your radio stations recently, is this song where he says, imagine there's no countries. It isn't hard to do. Nothing to kill or die for, and no religion too. Imagine all the people living life in peace. You may say I'm a dreamer, but I'm not the only one. I hope someday you'll join us and the world will be as one. It's a very famous song, but it's also a song where he dreams of living a life without boundaries. And as a psychiatrist, I know that living a life without boundaries is a dangerous life and is a life that will not work. We all need boundaries. And boundaries are God-given, as we will see later. We live with another longing. We are not dreamers, but we long for God's kingdom. We long for Jesus' prayer to be heard and to be true one day. Your kingdom come, your will be done on earth as it is in heaven. That's our prayer as disciples of the kingdom, as disciples of our Lord. That's what we long for, to see his kingdom come. It will come in the future because Jesus has overcome, but also now in our lives, the kingdom should be manifested. Because it is Christ in us, the hope of glory. That is in us. It's not in the future, but that hope is residing in us. And we have that peace in our hearts. You are in the world, you will have to suffer. Yes, the Lord did promise us an easy life, but cheer up. I have defeated the world. Those are the words of our Lord Jesus. He has defeated the world. And we should share this hope we have in him. And as he says, his disciples, they do things like when he is separating the sheep and the goat, he says, I was a stranger, but you did not welcome me. I was naked. You did not give me any clothes to wear. I was sick in jail, but you did not take care of me. So are we belonging to the goats or are we belonging to the sheep? That we welcome strangers, that we accommodate them, and that we help those who are in need. That's our calling. People have been looking at migration in a different way over the years, and recently an interesting book was published by Sonia Shah. She did an interesting study in migration, and she is like saying it that migration sometimes can be seen as a solution for many problems we have. Like in line with what John Lennon says, let's get away with boundaries. Let's have just one global village. Let's just share the world, share the global village. And from an historical point of view, migration has been, in ancient times, a response to many changes, to many challenges. And it was a biological imperative as necessary as breathing. Unhampered by borders, migration allowed our ancestors to people the planet, disseminating the biological, cultural, and social diversities that ecosystems and societies depend upon. So you may look at migration as a positive thing, and it is a positive thing indeed. And many people migrate to other countries for very good reasons. I've been a missionary for 18 years, and I was glad that was possible. And we were living in another country. It has enriched my life. I'm happy that was possible. And also the people in Malawi, I'm sure they were also happy that we were there. So yes, migration has positive sides, but also negative sides, as we will see later. And St. Paul said it like this on the Areopagus speech. It was a message to an ancient democracy where he said, he, that's God, made from one man every nation of mankind to live on all the face of the earth, having determined allotted periods on the boundaries of their dwelling place. God intended that they would seek him and perhaps reach out for him and find him, though he is not far from each one of us. There's no boundary between him, between God and us. Yes, we people have boundaries. We need boundaries. It is God-given to have boundaries and to respect boundaries. But through all that, God wants to come near to us. Let's not forget that. So people have been displaced. We have heard it. We've seen it nowadays, and there are 82.4 million people forcibly displaced. It was in the year 2020. And that's a huge number. And that number has been increasing since the year 2010. Every year since that time, the number has been increasing. And the main source of those who left their countries, the main country was from Syria. And then Venezuela is mentioned here, Afghanistan, South Sudan, and Myanmar. And 40% of those were hosted in only 5 countries: Turkey, Colombia, Pakistan, and Uganda. And Germany are mentioned here. This is from the UNHCR Global Report of 2020. And in the year 2015, it was the then UN High Commissioner for Refugees, Mr. Guterres, said, we are witnessing a paradigm change, an unchecked slide into an era in which the scale of global forced displacement, as well as the response required, is now clearly dwarfing anything seen before. That was in Syria. Whereas now we are in the year 2022, and it was last Saturday that I wrote down there are 3.1 million refugees forced to flee the Ukraine. By now, by today, it is reaching 3.6 almost. So that is a huge number of people forcibly displaced within the country, as reported by UNHCR. And then the humanitarian needs, because of this, of course, they are exponentially increasing. It's a major problem to Europe, to the Ukraine, to Poland, where many of these refugees are staying right now. So in addition to this, there are around 13 million who have affected in the areas hardest hit by the war. So that's apart from the 3.6, another more than 10 million. It's a huge problem, a huge disaster. So what can you do? What is the first aid you could give in situations like this? It is important to realize, we as medical practitioners, as medical doctors, that the basic needs are first. We have learned from Maslow's hierarchy of needs that it starts with the physiological needs. Those are on the bottom of the pyramid. People need to have water, need to have fresh air, need to have the basic things in order to survive. Secondly, they need safety. That's an important target to reach for when it comes to providing mental health, that people feel safe, have at least a feeling of safety, that not another disaster, another danger will affect them. Number 3 is the need for belonging, the need for those who are close to them, to family, to people surrounding them. Number 4 is the need for esteem, need for personal awareness and esteem. And then it comes to the higher needs like self-actualization, and as he mentions. But the starting point, next slide, is the basic needs. And even now, in such disasters like forced migration as we see, that still comes first. The basic needs are what is needed. Shelter is needed, food is needed, sanitation and hygiene is needed. That's the number one thing. If that is not there, well, you can send the psychologist in the corner of the room and ask him to do other things than to talk and to make use of his psychological skills. I mean, these things really come first. And secondly, after that is the second line of this. And here also, the source of the slide is an interesting website of the interagency standing on crisis. There's a lot of information there, a lot of PDF documents that you can download, what to do, what not to do in circumstances like this with people you interact with. So the second one is community and family supports. And that includes like tracing families, reunification. It includes like if someone who is in need, that you may help him with a phone, doing a phone call to a loved one, that he is aware that the other one is found, that he is, maybe they are separated, but at least he is aware where his friend, where his family members are. So that support is very important. Number 3 is focused, non-specialized support. And that can be given by any basic mental health care worker to help when there's like a panic attack, to give consolation, to give presence, and to help out with such kind of expressions of anxiety or mental need. When someone is hyperventilating, someone has a collapse, well, there's first need like that, where a psychologist or where any first aid of a hospital, of a medical people can address here. And the fourth one is the specialized services. And then you talk about specialized mental health care. And normally that comes later, like in the pyramid of Maslow, also the need for self-actualization, that self-awareness, that comes much, it's not a basic need, it comes later. And also here we will see that the trauma that will evolve, that will be a result of this war, it will come later. In Holland, we have the Center 45, which is a mental health facility in the Netherlands that was established after the Second World War and has become one of the most famous trauma centers, not only in the Netherlands, but even abroad. A lot of research has been done there, and they have been active for the past 70 years with those involved in the Second World War, but also the generations to come, the second generation who was traumatized through the first generation, etc. So we can predict that out of the crisis we see now in the Ukraine, the coming 70 years, if the Lord doesn't come back before that time, the coming 70 years, people will be busy treating traumatized people. We can really expect that. This is a real crisis, humanitarian crisis and mental health crisis that we still see very little at this moment, but a lot of things will come as a major problem. There are some do's and don'ts when it comes to first aid that you provide. First of all, let's go to the left side of the slide. Recognize that's the do's, that people are affected by emergencies in different ways. People have resilience. There are more resilient people may function well, whereas others may be severely affected and may need specialized supports. So people are different. Not everyone is the same. And use methods from outside the culture where it is appropriate to do so. You have to find that this person comes from another culture, comes from another way of doing things. So find a way that is appropriate to that person. If you are giving aid, if you're helping out and you have another cultural background, try to translate it, try to find out what is desired from you, and establish effective systems for referring and supporting severely affected people within the systems that you have. Do not establish something new, but try to do it from what is already available. Then we go to the right side. Do not assume that everyone in an emergency is traumatized. I mean, we may think and we assume that if I would have seen all this misery and all this disaster, I would certainly be traumatized. That doesn't mean that everyone else is psychologically traumatized. People differ. So not everyone will develop a PTSD. So people who are peer resilient need no support. That's another thing. Everyone needs support. Also those who seem to be resilient. A great lesson was learned from, I think it was in the metro station in London, where there was a major disaster a couple of years ago, that debriefing immediately after trauma, which was previously believed as an important psychological first aid, that people realized that those who were debriefed by professional psychologists immediately after the disaster were more likely to develop PTSD than those who had other kinds of support, like the basic supports I was mentioning in the previous slides. So do not debrief at once. Do not force people to speak on the severe things and the serious things they have just been seeing, they have just been going through. Debriefing in an early stage should not be done. Do not use a charity model that treats people in the community mainly as recipients of service. So realize that people, when they have gone through trauma, the first thing they want is to experience again that they have some kind of autonomy, that it matters what they want, what they decide, what they wish. That's one of the major, most important things you can provide for them, because they've gone through a trauma where unexpected things came their way. They felt completely unmighty, powerless. So if you help them to recover and experience a little bit that what they say, what they want matters, then you give them back autonomy, and that's very healing. Now let's go to migration, because migration itself, even when people have not witnessed traumatic experience, migration itself is a trauma. Especially when the migration is forced detachment. And here you see what is happening, what has happened in Europe, the pushbacks, where maybe you have learned about on our boundaries, where people are forcibly pushed back from Europe. It's a real disastrous thing to, as you see in this picture. It should not happen, but we know it does happen on the Greece borders and the borders of Hungary and Bulgaria, and it should never happen. But of course, you can imagine that if you want to go for a safe place and you don't reach that safe place, that is extremely painful, because they are in a survival mode. They have lost their security, they have lost their relationships, they have lost their possessions, lost their status, their work, their identity. Next slide. And they are moving, they are trying to reach another culture, another place where they feel safe. They go from culture A, where everything is predictable and everything feels safe, where they are attached. They have forcibly detached from that, and they enter into a new culture. And that entering into a new culture, if that takes time, the transition time, that so-called liminal phase, then it's very likely that mental health problems will develop. That transition period should be as short as possible, should be made as easy as possible. And we know that the European policies is to make that phase as difficult as possible, with the idea that if you make it difficult to cross the border, to cross the limina, which is another word for threshold, if you make that very difficult to cross the border, then people will be less interested to migrate, and you will stop them from migrating. But for those who really need culture bay, need to be accepted in another free country to experience freedom and safety, it is a disaster when this time takes too long. Because it's the liminal phase in migration that is a very vulnerable phase for anyone. In the process of migration, it's this phase that is characterized by ambiguity, ambivalence in social and cultural orientations of migrants. They've lost their identity, they've lost their personal, social, and cultural identity, and have not yet found a new one. And as long as they don't know that they are secure and that they are accepted, they stay in this phase, and that creates a lot of mental problems. It's what we call acculturation stress. When you go to a new culture, you can click on next and you will see a word appearing in the middle, anxiety. Anxiety is caused when you enter a new culture that you don't know. You have experienced defeat, you have experienced that there is no cultural predictability anymore, there's loss of autonomy, you have lost your status, your dignity, there's no healthcare, you don't know how to reach it, how to get in. So you feel really detached from anything that feels safe, even from yourself. You have no income, you feel minorized, the culture where you are, you feel that they are not really accepting you. As we see nowadays, when the people from the Ukraine come in Poland, when you have like a European face, you are accepted. But if you happen to be a Nigerian student who was studying in Kiev and you also are trying to find shelter in Poland, you are in big trouble. I mean, you feel really discriminated, minorized, and it will create many problems for them. So it was Stefan Hopeful who explained in a very nice document, a nice article, that when you are in your own culture, you feel safe. You know where to find your calmness. You know how to attach to things. You feel at home. You feel safe with yourself. You have hope. You know what will happen in the future, where you will go to school, where you will live, etc. And there is efficacy. You know, if I do this, the other person will do this. And so life is predictable. And if that suddenly falls away and it disappears from you, all these things to hold on to, there's all these white arcs you see in the middle, those things to hold on to in life, you suddenly have no access to them anymore. And you are at limbo, you have nothing to hold on to, and you need to find it out in the new culture. And it's another way of explaining that migrating is a real mental hazard. If the integration goes fine, people will develop an bicultural identity. They will feel at home the new culture, but they will also cherish the good things from their culture in the past. There are also those who want to forget exactly 100% their past culture, as if that never existed. Well, that's impossible, and normally these people, they run away for their own pain, and they will also develop problems. There are also those who do not want to integrate, and they keep stuck to the old culture, even in the new place where they are. And as soon as you enter their homes, you feel like even if you are in the UK, you have entered like a complete different culture. You're back in Sudan, or you're back in Eritrea, or whatever. And that is also not a healthy way to integrate in a new society. And there are also those who are estranged. They were already probably estranged in the culture where they came from, and they also fail to attach and to fail to integrate in a new culture. It has all been well described by Salman Akhter and a psychologist from Canada, Mr. Berry, how this works. So the importance I've already mentioned of resilience. There are people who have, like on the right side, you see the individual factors of resilience. There is personal strength and also personal vulnerabilities. But at the same time, there are factors from outside, environmental factors like your social support, your family, or the community that accepts you. Or there is like a burden in the environment, like stress, like trauma, like death, like things that are really stressful factors. All those affect the health and well-being of people in their migration. So a lot depends on that personal resilience and of if there is access to others who may help, who may support them. So this model can help you to see where someone can be best helped and assisted in the struggles he has. And migration, as I said, is a health hazard. And what diseases do we see after migration? Well, on the left side, you see 3 orange bullets. There's like the first one, the depressive disorders, anxiety disorders, PTSD, PGD, which stands for persistent grieving disorder. It's like a traumatic loss of someone. It can develop a persistent grieving disorder, which can take a long time for people to overcome. Substance abuse is a high problem in this target group, and also somatic symptom disorders occur more often in this group, in this population, than in the common population. Even psychotic disorders, we know that in Holland, for instance, migrants coming from Africa have a 2 times higher risk of becoming schizophrenic compared to other people. There's a suicide risk, which is also twice higher, especially among the men. And we know that the second generation that travels with the parents, when they see all these things in their childhood, they also have a likelihood of having developing problems later on in life, chronic health problems, as mentioned and as found out with the ACE studies, where you also find the references on the slide. Now, what do you do? What treatment can be given, especially when you come to like the treatment, not the basic treatment, as I've mentioned, but you come to a treatment where someone is already longer in your country, where you experience depression or PTSD. How do you treat that? Well, mainly psychotherapy will be helpful. You may support it with psychopharmacotherapy, but of course that does not help you to overcome the trauma and to overcome the memories. Sertraline is in Holland the #1 medication we use as a SSRI for people who have these high levels of anxiety, the sleeping disorders, because of the intrusions, because of the memories that are related to the trauma. Also an alpha blocker, which was a serendipity which was found that doxazosine and paroxazosine, which are antihypertensive drugs, through the alpha blocking, they had the side effect that bad nightmares seemed to disappear when using this drug. So they may help, especially in nightmares. Avoid benzodiazepines. It may be surprising to you, but it is in trauma patients, it's not the first choice because of the paradoxical effect it may have, that dissociation can be induced by the benzos and make things worse. So try to do it without benzos. Well, in the therapy, it's important that the talks take on, that there is a good trust between the therapist and the patient. Cognitive therapy is very helpful, where you need to have an element of imaginary exposure, where you go back to the trauma, where you relive the trauma, where all the senses are exposed, where you work through it and take your time. Narrative exposure therapy is at present, especially for migrants, a very effective treatment to come up with someone's life story. I have a next slide on that. And also the short eclectic PTSD psychotherapy, which was developed in Amsterdam, was very helpful to help people find out what the meaning is of the certain trauma. Because why is one person develops a PTSD, whereas another one who has experienced the same trauma does not experience a PTSD? That's an important question. And with we're trying to find out the meaning, the dynamics of the trauma, that may be very helpful also to go through that process. And then, of course, EMDR is highly effective when it comes to single pictures that are in the mind, that are having deep scars in the mind. Then EMDR is a very effective treatment to accept these things and to overcome all the emotions attached to it. Narrative exposure therapy is, it goes as follows, that in your sessions, you go with the patient, establishing his lifeline. And you do that with a small cord, and you say, this cord symbolizes your life. You can shape it in the way you want to shape it. You put it on the floor together, and then you give the person some flowers and some stones, and you say, you can place flowers where you have positive memories, and you place a stone where you have the bad memory. But I want you to have always after a stone a flower as a positive memory. And then they set up their lifeline, and they alternate their stones and their flowers, and it creates a lifeline. And in the first session, you look back and you make that, you write a short note to each event and say, well, now we go in the coming 16 or 18 or 22 sessions, we go through all these stories together and see how the emotions then and how the emotions now interact with each other. And you read down the story, they take the story home, they read it for themselves, they read it out in the next session, and it's a highly effective way of coming to yourself, people accepting themselves again. Because one of the main issues of a trauma is that when you look back after a traumatic event, is that you only memorize the trauma, and everything good that happened before it, you have no access to it. And so this treatment brings also back the healthy memories, the supportive memories where people feel attached. So they really come to themselves and they see the traumatic events in line, in view of their life development. So it's a very powerful way of doing therapy. In all this, it is so important that you develop an approach, you develop your cultural competence in your approach in dealing with the patient. Cultures are not static. If you say cultures are static, it's a mistake, because this diagram says if a culture is static, you go to the left side, it says the differentiation is then you develop a we-they thinking, and you start generalizing. You start stereotyping and stigmatizing. You develop your own confirmation bias. You see it back all the time. You confirm yourself all the time. And then you develop poor aid in healthcare services. So cultures are not static, and you need to develop cultural competence. That means that you shall not harm by stereotyping. Do not predict to say, well, this person comes from another culture, from another country. And that's because he's doing like this. No, take your time to find out what really the patient says in his own words and with the perspective from his own culture. So that's part of evidence-based medicine, that you respect the patient's values and preferences. It's also in this graphic explained that the further your culture is away from your own culture, from your own way of looking at things. It's on your left side, the vertical one. Down in the corner down, it's like easy, where, well, it's like a culture that is quite close to yourself, like the Anglo-Saxon, the British and the Dutch. It's not so far, it's not so complex. How we look at things, it's almost the same. Whereas when you go up, the vertical one, it becomes complex if it is like, yeah, you may speak the same language, English, but it is in England and in Nigeria can be quite different. And on the horizontal one, you see when things are biosomatic, it's like a broken wrist, or when things are psychosocial, it's like personality disorder. Well, that's much more complex. So the closer you are together as a doctor and a patient when it comes to your culture, the easier it is. And the more different your cultures are, and the more abstract, the more psychosocial the disease, the disorders are, the more complex it will be. So let me come to my conclusion. And that is, when you meet people, when you address needs in refugees, basic needs first. That's the priority. There is shelter, food, hygiene, that comes first. Bring them in contact with family members. and show them that their autonomy, their choices do matter. So recreate an opportunity for experiencing autonomy. And then allow for mourning the loss. I mean, cultural detachment, losing your culture is like a loss of a dear one. So allow for mourning the loss, also the loss of culture, the loss of predictability and everything related to that. Develop in your language with and in your way of treating people cultural competence, as I've given you some points here. And welcome to fully integrate an extended liminal phase is harmful. So be activist, lobby with your governments that delays in this process will create a lot of morbidity on the long term. Make sure that people, when they come, they feel safe as soon as possible. I think this is my last slide, and I want to end here.
Thank you, Bert, for that excellent overview and analysis of the factors and highlighting the various ways in which we can respond to it. There are quite a bit of questions here. Let me start off straight away with some questions. Dr. Deng, Yusuf Deng from South Sudan is asking, are the issues different for those who are internally displaced, or is it similar? What can you advise for those who are internally displaced?
Yeah, so for those who are internally displaced, the cultural differences will not be so big because they are accepted. They have found a place within their own culture, which makes it easier. They have not to change their language, etc. So probably that will make it easier for them. But even there, the internally displaced people often they may be in poor circumstances where access to healthcare, access to facilities may be hard. So it's important that the NGOs who are operating there, who are working there, join hands to make sure that they find a way that services will be accessible.
Thank you. Yusuf also has made a comment and a question. In a setting where you don't have a psychiatrist, what can be the mode of interventions? And I suppose this is true for many of our national organization settings in the southern continent. Any thoughts on that?
Yeah, where there's no psychiatrist, I mean, many countries are like that, and the basic services, you don't need a psychiatrist for that. I mean, it's even better not to have a psychiatrist for that. Other people can do much better there. So that's the number one. The basic needs first, anyone can provide them. But if you feel like, I mean, we all know, we all have learned how to address a panic attack when there is hyperventilation. You have to reduce and you have to make sure that the stability in the body comes back. You have to reduce the breathing. Someone has to breathe in his hands or in his, well, to calm him down. Or some people will be very happy when you touch them and you make them feel that you are present. It will help them to calm down. Others will reject it and they will say, no, leave me alone. I would rather be alone. Well then, okay, allow them to be alone as long as they don't do dangerous things, which they shouldn't do, because then you may have to limit them and you may have to create boundaries where you will hold them and hold on to them, that they don't do things they shouldn't do. You need to protect them from doing harm to themselves. Breathing techniques will help. And the understanding, to the explanation that the body with the anxiety reaction is a normal reaction to anxiety, is a necessary reaction, but it is a reaction, and it should not become something that should be repeated all the time. Those things can be explained. The flight and the fight and reactions, the responses, the freeze, the three Fs.
Yeah, fight, fright, flight reaction.
Yes, so you can explain those, that they are very helpful, very necessary in in the animal world, but also with humans, but that they should not become something when there is no need to be afraid anymore, because now you are in another place. And that's the second thing, that you may always reassure, now you are safe. It was horrible. Yes, it was horrible. Acknowledge it. But now you are safe. So that you create a sentence in them, it belongs to the past. It belongs to the past. That will help to create distance from where you are now compared to where the problem of the trauma was. So create that distance, it belongs to the past. Also, when you yourself hear these stories and see the traumatized people and you are affected by it, sometimes close your eyes and say, it didn't happen to me. It did not happen to me. I'm here, I'm safe, I'm healthy, I can assist these people. But oh, I'm so glad it didn't happen to me personally. Otherwise, you may be secondary traumatized yourself.
Thank you. I think it also means that all healthcare providers should be good counselors and should know primary psychiatry, the basic systems of caring for a person who is mentally, who is going through a grief and challenge.
Yeah.
Jennifer is asking that are the issues similar to children removed from an abusive household and placed in foster care, attachment and safety issues? Are they similar in refugees too?
Yeah, she means that there is a risk of abuse, or, well,
No,
yes,
no.
it's
Issues,
true.
are they similar both
They
in
are
foster?
similar. Yes, they
Yeah.
are similar, because they see the experience also the fear of the parents. They see the fear, and they translate it with themselves. They carry it with them. So they are traumatized through what they see in their parents. Yes. And their parents have so much emotionally to carry themselves that there is normally no time to support their own children. So they have they are denied what they need right at that time. So yes, there is they have a loss of proper affection, which is harmful to children.
Thank you. Somebody has put a question on the increased risk of developing schizophrenia among refugees from Africa. He says that he always thought that environmental factors were always almost irrelevant as compared with genetic and biochemical factors in schizophrenia. What are the thoughts on etiology of this phenomena? Are they possible co-founders or factor contributing to ending up as refugee being associated with schizophrenia? The whole question of why there is increased risk among refugees
Yeah,
from Africa.
well, it's a puzzling question, which is an ongoing puzzling question. Why? Why do we see in Holland that migrants who come to work in the Netherlands, their children, when they come from Morocco, have a much higher risk of developing schizophrenia than if the migrants come from Turkey? And one of the ideas is that the larger, the greater the differences are between the two cultures, the greater the risk. Because when there is a huge difference between the two cultures, from one culture to the other, those who come from the other culture as newcomers, they experience what we call social defeat. So they experience that they do not belong, that feeling part of the new community does not happen to them. And so because of that, because there is no feeling of belonging, there is a lack of feeling attached and feeling safe, which goes on and on and on, then that is creating them to have a higher risk of developing schizophrenia. So the social defeat theory is one of those that is mainly used here when it comes to people coming from another culture.
Thank you.
That's in brief what I can say. There's much more to say about it, but this is one of them.
Yeah. A couple of questions on benzodiazepines. Jennifer is asking if a person is asking for diazepam, is it okay to give because it is his or her autonomy. At the same time, somebody else has asked what is a good sedative to give, insomnia, treatment for insomnia in that context.
Yeah. So as said, the diazepam has a risk of increasing dissociation, because what it does is that the sense of having control over a situation is lost. People feel a bit alienated, they are like sedated, but also feel that their autonomy, that they can do something, that they can influence their direct environment, is disappearing from them. So they find it very uh, anxious to experience, to go through this. So it's a paradoxical reaction that you see in traumatized people more often when they use the benzos. So that's why we try to avoid it. What can be given is the SSRIs, like the sertraline. It's a very effective one, but it doesn't work immediately, and you have to wait about 3 weeks. You go from a low dose, 25 milligrams for 4 days, you go to 50, then a week 50, and then 2 weeks 100 milligrams, and then the third week you are at 150 milligrams. That's how I normally start it, and that's effective, and that reduces the general anxiety, improves the sleeping pattern, and therefore reduces, is very effective. On the immediate result, I normally prescribe quetiapine, Seroquel, in a very low dose, 25 milligram only, before the night. That also helps people to calm down in a very effective way, and it is not addictive.
Thank you. Thank you for that. Angel Wong is talking about her experience in a refugee camp in Thailand, Myanmar, and Burkina Faso. And she says that she totally agrees that it is the creative, spiritual, and cultural aspects are very real. The question is, what can we do for the for refugee camps in many European countries caused by the European war this month? What are there any ideas if you can send a short-term mission team? How can it be done? What kind of services should be there?
Well, many teams have gone to Poland and to Moldavia and Hungary to welcome the refugees when they arrive, so that the basic needs are provided. Many churches have been assisting there, many volunteers. So that's one thing that provides in the basic needs. And yes, if later on, I hope that we will get through, maybe through our colleagues in Poland from ICMDA, we may get invitations, we may get like opportunities to go for outreaches and for activities to help out, because yes, the lack of need and the lack of access to healthcare will be great, and there will be a great demand. So maybe, yes, we should have an eye on it and see where we may be able to assist.
Thank you. One of the questions from Iona is, with the refugees from Ukraine has lived a mass traumatic experience, do you think a group therapy, trauma therapy perhaps is indicated? She's from Romania and Austria, where she works, are limited.
Yeah.
You cannot give one-to-one therapy to all who need.
We are currently also considering in our health facility, when refugees from the Ukraine will come near to us, that we also may offer them indeed a group therapy, because we may have so many patients that we cannot start with individual therapy, and that you start with the group. And because they all speak the same language, it will make it easier. But do a group therapy and start with the basic things, like basic breathing exercises, explanation on psychological principles that we know and that you share with them. And so they recognize, oh, so it is normal that I have these bad memories, that they come back during the night, etc. So a lot of explanation, psychoeducation will be very, very helpful in this group. Yeah. So I would really support to do that in group therapy, but do not allow them to share their traumas with the group, because that should not be okay, because then others are traumatized again.
So there are some things you can do in a group, but some things cannot be, their sharing should not happen. I think there are a lot of questions coming in. Let me try to pick up some key important questions. One question is, how can in this Ukraine situation. I know importance of resilience. You talked about importance of resilience among refugees. Can it be done online? Can it be that kind of a support system by Zoom? How can a common dentist or a MD, general medicine person, physician who's not trained in psychiatry, be helped or given some aids to do this? Are there some thoughts on it?
Yeah. Well, through the corona pandemic, we have now access to these things like Zoom and Teams and all kinds of other means of connecting to people even online. And so indeed, it will help. It is at least something that you can help and give assistance and help people out. So yes, that is definitely something we can make use of, because we have no access to go to certain places, but through this we can still share information, we can still explain things, we can be in contact with people, and people help them. I mean, a lot of psychologists nowadays do their treatments online. And it works. Even EMDR is something that can be done online. I mean, there are many techniques that can be made use of. So yes, online is an opportunity, and make use of it where appropriate.
A question on semantics, words, is that some of the families from Ukraine, they are in Romania and Poland, and they see it as a temporary situation, and they don't want to be called as refugees. So, have you seen this? Is this an important issue to think about as a question?
I don't get the question right. You mean people do not want to be seen as refugees?
As refugees. They see it as a temporary dislocation and they'll go back. So they don't want to be called as refugees.
Yes, that's true. I mean, they really hope that they can go back soon. They are displaced. So yes. I mean, if they don't want to be called refugees, because there's also the issue of feeling shame and feeling guilt for not being present where they should do something. They have the feeling that maybe I should have done something, but now I'm outside the country. And so that guilt is maybe why they don't like the word refugee. Yes, well respected.
The whole issue of how the locals getting weary of increasing number of migrants and complaining about refugees taking away jobs and resources and the dynamics involved in that. Is that something significant? How do you deal with that? A question from Abhijit.
Yes, I think at present in Europe, all over Europe, there is like a overwhelming acceptance and willingness to support right now because of the crisis. But the longer it takes and the higher the demands will be, yes, it may become a problem. Yeah? And we already see now the tensions between the refugees coming from the Ukraine and those who are still coming from Syria and from Afghanistan. That people really prefer to help the Ukrainians and not the Afghans, whereas they are equally in need. So there, yes, you see those tensions. And one of the problems I foresee is that the support we may be willing to give as Christians is not so broadly recognized as something we need to do as a whole Western community, because we have become selfish and we have become, well, very materialistic, and not all of us are willing to sacrifice so much. Our wealth is very dear to us, and somehow we are greedy. So when things are getting longer, you will see right-wing groups who will not be happy with this and who will may cause problems. Yes.
A question on what is required to start up an NET, NET.
Yeah.
You talk. What are the basic things required to set up an NET as a doctor?
So you need to have people who are trained in this, because you need some basic training in the narrative exposure therapy, how it works. And well, there are some good guidelines. I have given them in the slide. You can find them at ARC Center 45. They have a complete PDF that you can use. And it's not so difficult to make use of it, but you need basic psychological principles. You need to understand them because people really have to go back to their traumas, which, which may cause dissociation, which may cause anxiety, which may cause a lot of emotions. And you need to be there, present, work through those emotions. So, yes, you have to learn it, and you have to be competent and confident in doing it.
Thank you. I think we are over time. So thank you Bert for joining and sharing this overview and lots of information on how we can practically engage. Thank you once again. See you next week.
Thank you. Bye-bye.